Our next speaker, I am absolutely thrilled to introduce to you. We're going to kind of breeze through our breaks and just to get back on track since we started a little bit late. But that doesn't mean you shouldn't move. In fact, our next speaker is going to talk to you about movement. And so without further ado, I want to introduce you to Mariska. We're so honored to have her here today. There she is. I took her training earlier this year, and she's a wealth of knowledge. I don't know where she learns everything she does, but there's so much she knows about. So you're in for a real treat. Let me just tell you a little bit about Mariska Breland. She's a certified Pilates teacher for MS. She created the Neuro Studio. In 1999, Mariska took her first Pilates class. After a 2002 diagnosis of MS, she became a devoted yoga and Pilates practitioner and taught her first class a year later. You didn't waste any time, did you?
Not really.
She then founded Fuse Pilates, a contemporary Pilates method and studio based in Washington, D.C., for which she developed all of the group classes and training programs. She's also an inventor of the patented Fuse ladder. And I think I need to go do some of that music therapy. That might help. Mariska completed a research project on Pilates from MS patients as part of her comprehensive Pilates certification through Body Arts and Science International. She later expanded that research into an in-depth, multi-day Pilates for neurological conditions teacher training course and incorporated the latest research in neuroplasticity and neurorehabilitation into a program designed for people with MS, stroke, Parkinson's disease, and other neurological conditions. This year, as if that's not enough, she launched the MS Master Plan, the most comprehensive single source for MS patients in existence, covering over 275 videos, including interviews with experts and patients about everything from diet and exercise to understanding how MRIs work and how to read the results from successful strategies for disability and workplace claims to the psychological ramifications of an MS life. As a student of medical neuroscience, Mariska has also designed workshops that focus on how to integrate brain science into exercise programs to enhance performance and improve neurological function. Take it away, Mariska, and I'm so excited to hear your journey with MS as well as your presentation today.
Thank you so much. I'm so glad to be here. And also, she gave such a long and in-depth introduction that I don't feel like I have to do much of one. But my presentation today will include some of my journey and sort of, I'm sure a lot of people who are in this presentation paying attention are going to see some things that they recognize in their own journey. So on that, I'm going to share my screen. I'll pop in and out of it. So today I want to talk about understanding mobility. So basically understanding movement. Mobility also goes a little bit into our understanding of flexibility and sort of how we get tight and how it becomes hard to move. And what I hope by the end of this is that you have some different ways to think about why movement in multiple sclerosis can be limited and things that you can do to make it better. So first thing, most important thing to know is that our brains are very, very smart, even when they're doing things that annoy the living hell out of us. Your brain is only going to allow you the amount of mobility that it feels safe, which means that things like spasticity, things like problems moving that we have a lot in MS are not necessarily bad things, even though they might feel very bad to us. So what makes it hard to move in the world of multiple sclerosis? There's lots of different things that can affect it. And a lot of times, and this is kind of where I started my journey in trying to figure things out, We address the area of concern. A lot of doctors say you have foot drop, so let's look at the foot. Let's look at all of the things about the foot. And then it doesn't actually work. Sometimes the thing that actually improves what you need to work on isn't the thing that's the problem. The previous speaker was talking about acupuncture and talking about sometimes addressing the neck. You might be doing something in the foot. It's not that different from how I would look at things in terms of the body. I wouldn't look at just the foot. I would look at the entire system. So foot drop. Foot drop was not my diagnosing symptom, but it was my second big flare up. And it's the thing that to this day, sort of foot drop and spasticity are the things that I deal with the most in terms of having 20 plus years of MS, like what's actually affected me. So some of the issues in terms of foot drop and getting your foot to lift when it doesn't want to lift is that one, your foot is really, really, really far away from your brain. So things that are far away from our brain tend to have the most problems when it comes to neurological diseases, because there's a lot of neural pathways that have to be traveled to get from your brain to that muscle. So the muscle that lifts your foot is called the tibialis anterior. It's a teeny tiny little muscle far away from the brain. Another thing, which also kind of plays a role in foot drop a lot of times, is muscle spasticity. So muscle spasticity is a tightness that is reserved for us with neurological conditions. So you only get muscle spasticity if you have damage to the brain or spinal cord. And spasticity is actually a protective reflex against the stretch reflex, which they test when they like hit your knee with that little hammer. They're testing the stretch reflex. And when you have an overactive stretch reflex or a stretch reflex that won't turn off, you develop spasticity, which is this tightness of muscles that we experience. Now, we also experience regular person muscle tightness. So regular person muscle tightness is something that anybody can experience. And that would be like if you sit too long, if you have bad posture, muscles get tight. Tightness is still a protective thing. For instance, right now I have a rotator cuff tear that has nothing to do with MS at all. It has to do with me trying to stop something from falling by reaching back behind me and tearing a tiny muscle in my shoulder. And so now I can't lift my arm all the way up to the ceiling because it hurts. So that's another thing that can protect from moving, is if you have pain. So a lot of times in the world of multiple sclerosis, we have pain. Oftentimes that pain is from inactivity or it's from moving incorrectly. And some of that incorrect movement is because of muscle spasticity or tightness or foot drop or things like that. Balance problems are other things that we deal with that affect mobility in a negative way. In terms of balance, there are 3 neurological components about that. So your visual system, your vestibular or inner ear, and also your proprioception. Your proprioceptors kind of tell you how your body is leaning. So we have a lot of proprioceptors in our feet, for instance, but you have them all throughout your body. They're sensors in your skin, muscle, and tendons. And so if we can locate the source of the balance problem, whether it's neurological, like is it because you are dizzy all the time because you have a vestibular issue, or is it because you can't feel your feet and that's affecting proprioception? That would change how we might address that to improve your mobility. Is it musculoskeletal? So if you have really tight calf muscles, for instance, because of spasticity, that can affect your balance. Or often in the neurological world, it's a combination of those things. And then also when people have sensory issues, so there's sort of a lack of connection and you have a perceived instability because you can't feel something, or you feel things incorrectly. So if you have a lot of loss of proprioception in your hips, you might lean more to one side and you don't think you're leaning to one side. You think you're standing evenly in both feet, but that sensory disconnect can be something that can make it more likely that you would fall or that you would have movement problems. So as you can see, there's lots and lots of places where things can go wrong that negatively affect how you move. Now, in terms of my story, I had what a lot of people in the relapsing remitting MS that I'm probably in secondary progressive, who really knows? I don't know how they can definitively tell you that. But I've had MS for 20 years and that's kind of a long time. So in 2003, so I was diagnosed in 2002, but shortly afterwards, I ended up with foot drop. So I went out drinking, doing shots with friends one night, last time in my life I've ever done shots. And I woke up the next day and my foot was literally kind of floppy. And I also I couldn't feel my left hand. And it was the worst flare-up I had to that date. And I couldn't really walk for about 6 weeks. So roughly the time that most flare-ups last. So it was like 6 weeks. And then things kind of started getting better. But I very, very, very likely had residual weakness in lifting my foot. But like most of the time, and people have early MS, I felt like all of my issues had resolved. Like I felt like I'm walking normally again. I could wear flip-flops, which I haven't worn in years, but I felt like walking wasn't really a problem. But I had some sort of residual weakness. Now, at some point, I developed spasticity first in my calf. And I didn't really realize I had spasticity until I was on a trip. I was actually in Prague. And if you've ever been there, they have like the cobblestone streets. And I was wearing heeled shoes, which you can't really wear on cobblestone streets. So I went and bought a pair of flat shoes. And I was just catching the ball of my foot on all these rocks all the time. And then I noticed that my calf was really tight. It just felt tight. So at some point I was developing spasticity. It wasn't until 2008, so we're talking 5 years post foot drop, that my ankles started to hurt. So first visit to a doctor, which at this point was a podiatrist, to say that my ankle was hurting. So his thing was, doing orthotics and whatever, which didn't really help much, but I was walking less. And then as I was walking less, the muscle spasticity was getting worse because I was using my ankle less. It was getting weaker. So at some point, roughly around 2011, I could not actually lift my foot up. Physical therapists could not get my foot to lift up because I had something called an ankle contracture, which I still have to this day, which is something where you get so much tightness around the joint that the joint doesn't want to move. So I can't lift my foot more than, like, I can stand flat on my feet, but I can't lift my foot up from standing flat on my feet. And so then, because I was really hard to walk, I was walking less, and then I was getting more weakness, and so forth and so on. So less walking, more spasticity, less walking, more spasticity, less walking, more weakness, more spasticity, more weakness, less walking. So it was just sort of this cycle that was really hard to beat. And I ended up going to, trying lots of things to try to fix this foot drop, ankle contracture, spasticity issue. And at no point working on foot drop did my walking get better from working on the thing that I thought was the thing. So foot drop is one of the most common causes of gait or walking problems. And walking problems in neurological conditions are compensations that we use to get around a foot that does not move properly. So for me, I tried stretching. I stretched. I would sit in front of the TV with one of those stretch bands, and I would fold forward, and I would stretch, and I would stretch, and I would stretch, and I would stand on the edge of stairs, and I would stretch. I would do yoga classes and stretch, and nothing worked. And then I did round 1, 2, 3 of Botox. I did myoblock, Botox, and Dysport. So I covered the whole range of Botox options with serial casting. So serial casting is where you have, I didn't do a cast, but I did a brace where they increased the amount of stretch on my foot consistently over weeks. Well, I also have neuropathic pain or nerve pain in my foot. So I would end up ripping the cast off in the middle of the night because my foot would hurt too much. But at no point did I actually get more range of motion. I just actually felt weaker when I tried to walk, which is actually a common thing. And one of the reasons why I don't actually like what I would consider overstretching for foot drop or calf spasticity, because it does increase weakness in your calf, which actually makes walking harder. And then I was doing exercise, which helped some, but when I was exercising my foot, I wasn't really getting much better at walking, or if I was getting improvements at walking, they weren't sticking. So one thing that's important to know is that it is going to be really hard to move if we aren't stable somewhere else. So if I wanted to, for instance, lift my foot off the floor, and I'm going to show you guys this in a little bit, but if I wanted to lift my foot off of the floor, I need to be able to balance on my opposite leg. If I don't have stability in my opposite leg, it's going to be impossible to lift my foot up. So you start to go up the chain of the body. So we're looking at the foot, we're going up and we're seeing like, where else is there weakness? Where else could there be potential to get better movement? So where we see weakness often are first the glutes and hamstrings. So your butt, the back of your legs. And when you're walking, you really need to have strength in these muscles, or also when you're standing and balancing, to be able to push your leg behind you to get forward momentum. So walking is almost sort of similar to swimming, where you would have your arm reach forward to push you back. Your leg reaches forward, and then your leg ideally pushes back behind you to give you forward momentum. So to have that, you need to have strength in the back of your legs. You also need to have strength in your quadriceps, which is the front of your legs. These are common areas for spasticity, and this is actually where you see a lot of problems in terms of falling. So if you don't have the ability to bend your knees kind of slowly to sit down, or bend your knees sufficiently to sit down, you kind of kerplunk down, or you might fall to a seat, which has a high risk of falling, which is not ideal. But coming from standing to sitting is actually one of the probably top 3 ways people with MS end up falling. A very, very big deal are the hip stabilizing muscles. So the hip stabilizing muscles are your upper outer butt, and then your outer thighs. So your upper outer butt muscle is called your glute medius, and that is designed to keep your hips level and then to move your pelvis as you're walking. And if you don't have strength there, your balance is probably going to be pretty bad, and your walking is probably going to be pretty bad. So when you see people with foot drop, a lot of the times you're going to see hip weakness as a very big factor in how somebody is walking. And that's sort of our main demonstration thing for today. And then also the upper body. So it's not just the lower body that's the problem when we have walking issues. The forgotten part of the body that a lot of times tends to be the bigger issue is the upper body. So if you are unable to hold your posture upright because you have weak core muscles, which would include your abdominals and also your back muscles, then you're basically falling forward when you're walking. It's going to be harder to lift your feet up because your weight is in the wrong position to lift them up. And we also use our arms when we're walking. So when people don't use their arms at all, that can also become an issue. So there are connections that go all the way through your body. So when you take a step, so let's say this guy with the arrows on him is taking a step with his right foot. So let's say he's weighted his right foot. So his weight is on his right foot. There's a force that goes up through your body. So it goes up your leg it crosses through something called the posterior sling. So it crosses from your glute through, fancy term, something called the thoracolumbar fascia. So the fascia, which is an area where you get the knots in your muscles, that goes from your right side through your lower back on your left, up to your left shoulder, down through your left arm. So when we walk, when we're stepping forward with our right leg, ideally we're swinging our left arm forward at the same time. And that's sort of the way that force should be traveling through your body. This is also something that happens called a central pattern generator, which is a reflex that is a spinal reflex that when you walk should be kind of turning on. And walking is actually something that is a reflexive action, which is why for most of us who have muscle spasticity or foot drop or something like that, it's hardest to walk when you start walking after you've been sitting for a long time, or if you even have to start walking after you've been standing for a long time, because that reflex has ended up turning off and we need to turn it back on. And then for the force to travel correctly, you need to have strength and stability in all of the major joints. And we're going to say, especially the ones closest to the core, the center of your body, which would be your hip and your shoulder. So the way the connections work is it's shoulder to opposite hip, knee to opposite elbow, and wrist to opposite ankle. This is a lot easier to see when we think about quadrupedal animals, so like a dog or something. So when a dog is walking and they're in a quadruped, so they have 4 legs instead of arms and legs. So when they go forward with their right paw, their left paw also goes forward. So their shoulder of the right side is connected to the hip of the left side. The elbow, I consider that my dog has elbows, especially when she sits on me and sticks her elbow into my body in some way. The elbow to opposite knee and the wrist to opposite ankle. So that's kind of how the connections go. So let's say you have foot drop on your left foot. That's connecting all the way up to your opposite wrist in terms of how that force kind of goes through your body. So I know I'm going through this kind of fast, but that's because I want to have time to answer your questions. So in terms of finding stability for better mobility, I wanted to show you a couple of different things, and then I will answer your questions. So I'm going to switch over, or Mindy, maybe you can do it. Can you switch over to my other camera? Okay, so my site is theneurostudio.com. So it is all exercise it's basically like a workout site completely targeted to people with neurological diseases, divided up by symptoms. So you can look for exercises for foot drop, for balance, for spasticity, for bladder bowel issues, like literally anything that is a common neurological symptom, we have exercises for it. And then the MS master plan is also on there, and that has, it's 27 hours of content, but it's all divided in like little 3 to 20 minute videos. That's on there. And we do have like free trials for the Neuro Studio if people want to check that out. So there was a question about the difference between Pilates and yoga. They are totally different. So yoga is more of an exercise thing that is based on also meditative movement. In the Pilates world, we are very much based on exercises that move, that are connected to the core, that work like the small muscles that a lot of times are forgotten, like the rotator cuff muscles, the hip muscles. We have lots of crazy machines. We use spring weight. It's a very different thing. I always think it's funny that people think they're so similar, because I think they're so different.
Yeah, I get that. Sometimes I'll say I'm a yogi and they'll say, oh, I do Pilates. And I'm like, can't you?
Well, no, that's not the same. I mean, I like yoga and I have done a lot of yoga, but I they're completely different. I think Pilates is a very nice complement to yoga because it does make you better at doing a lot of things in yoga. Because you need like a lot of core strength if you want to do some of the crazy stuff like arm balances and things like that. But we are more of a workout, and Pilates, Joseph Pilates, who's the person it was originally named for, was a boxer and like an athlete. He did do yoga, so there are some stuff that you'll see, and we'll name it a little bit different, and we might do it a little bit different. But he also did a lot of rehabilitative work, so it's more in the rehabilitative work. So when we were talking about how you need to have stability to be able to have ability, and how we can address different body parts that aren't the problem body part. So problem leg for me, MS leg, is my left leg. So a couple of things that you might see. This leg is kind of turned in some. That is muscle spasticity from 20 years or so work. And then I can lift this foot up, and I can't lift this foot up at all. Like I can lift my big toe up, and that's all I've done. So in terms of walking, what I found that I did originally when I had foot drop was when I would take a step with my right and I need to get my left foot to come through, what I would do is I would swing it around. So that's called a circumvention. At the same time as I'm doing that, I'm actually dipping into my right hip. So that actually means that my left foot, if I was trying to lift it off the floor with my right hip kind of sticking out over here, it's going to be harder to lift off, because if I was walking without having MS issues, what would happen is if I step forward with my right foot, I'm not sinking into this leg, which is what you ideally are not doing. I would be actually lifting up out of this leg, so this leg would be pushing in more. So that is the glute medius muscle. And then this leg doesn't have to do as much work to step through if this hip isn't kind of collapsing in. So an idea of like having to have that stability to have mobility, I want to show you by making myself extremely unstable. So I'm going to sit in a chair, and I'm going to try to lift my left foot without having my right foot be able to touch the floor. So this is spring weight. So this is a Pilates thing. So springs, like literally like what you would see it as a spring, but we use them in different ways. But if I put my foot in this, at this point, I can't push my foot down to the floor to stabilize myself. So if I can't get this foot down and you tell me to lift my left foot up, I'm going to have to do some crazy things. So I can like lean back and then lift this foot up, which would be some very strange walking if I was doing something like that. But if I just have this foot in, I literally cannot, I can lift my heel up, but I cannot lift my foot up. Now, if I put my foot on the floor and I'm stable, meaning like my hips are down, my feet are down, this is my weaker MS affected side. I try this so you can see it a little bit better. Weaker MS affected side, I can lift it off the floor if I can push down in this leg, which means that this is my leg that's creating stability. I can push down. If I want to feel more stability, so maybe this leg wants to roll in or wants to push out too much, I can try placing my hand on the outside of the leg or the inside of the leg and push leg against hand in either of those positions and see what feels like it's easier to move. So I know that for me, I need to work on my right hip. So we're talking about how is that force traveling up. So the force is traveling from my right leg when I need to step my left leg forward. So the force goes up my right leg, behind my back, down my left arm. So I also need to have my left arm move forward. So my right leg is stepping forward, because that's how the force is going to work. But for the purposes of us not having a lot of time, I just want to do a couple of exercises using a yoga block as your yoga people. So if I want to get my right glute to not want to dip out as much. I need to strengthen the motion where it pushes in. So I can do that using a block in a lot of different ways. I think you'll be able to see me okay here. So I'm going to place my right knee on this block to actually exaggerate how much it kind of goes out to the side. So from that exaggerated position, what I want to do is I want to push my hip in, and to make sure that my hips are level, what I'm going to do is I'm going to lift my left off the floor so that my sacrum, so the back side of my left, is going to be level enough, I always say, to place a martini glass on it. So I can dip down, which is like where my hip wants to be, and we'll work on pushing to get my hips to be level. You can do that also from a standing position, which is a little bit harder. So you can stand on something where, let's say you're here, you want to level off. So if you could look like in a mirror or something, you could say, okay, are my ASIs, so these are the two bony parts in front of your pelvis, are those level? Try to get those level and hold on to something if you need to hold on to something. And then you could also do it as a yoga bridge, or like it's not a bridge in yoga, what is it? It's just like a pelvic curl. So it's like a little baby bridge. So if I was down on the floor here and I lift it up, I'm going to try to lift my foot up so that these two bones are level. So it's again working that outer hip muscle that we want to have be stronger, so we're not dipping into that hip. And ultimately, what we want to do is making walking easier. So I'm concentrating on not dipping into this hip. That's really hard to think about all the time. It's like push, like try not to dip into your hip, try not to dip into your hip. So I don't actually love that as a cue for people. I prefer to make cues really easy. So think tall. You're going to be as tall as you can be. Tall without doing this, which I think a lot of people do when you say be tall, which is stick their chest out. I don't want this chest out kind of tall. What I want is crown of your head, like if I had a ponytail, crown of your head lifting up towards the ceiling. So instead of sticking out like this, you're thinking you're kind of pulling your abs inward, which would be a Pilates thing. And then think about your knees being soft and that your soft knees are leading you forward. So I didn't gain any ability to lift my foot up. I have tried to lift my foot up forever. I've tried all the things to lift my foot up. What I want to do is think about not collapsing down and making it harder to lift my foot up. I'm just thinking about my soft knees and tall spine moving forward, because to walk, you don't actually need to be able to lift your foot. You need to be able to take your knees, move them forward, and not let your foot just drop. So I don't have the ability to lift higher than not letting it collapse down to the floor, but I can walk without an AFO or anything when I do remember to do all of those other things. Now, that being said, I am not anti-AFO. I have an AFO when I go on really long walks, or walks when I don't know what to expect. What I do is I wear an AFO, and sort of my other cheat is to wear a heel that's like a nice fat heel that's like about 1.5 inches or maybe up to 2 inches, because that actually pitches your weight forward in such a way that's beneficial if you have spasticity that you kind of can't work around. But that would be something that I wouldn't necessarily recommend to everyone. That's just kind of a case-by-case scenario, but getting that idea of lifting up and not collapsing into your hips and thinking about things that aren't the problem, but are the fix, I guess would be a way I would like to have you guys thinking about it. If anyone has any questions.
We just have a little more time. There are some good questions. So one is, do I need specialized equipment for Pilates?
No, we have actually a lot of stuff that we do on the mat. We use little things like TheraBands and stuff like that, which I mean, you can get for literally just mere couple of dollars. I mean, I have stuff that if you add up everything in this room is probably about $30,000 worth of equipment, but I also teach people. So Pilates equipment can be very expensive, but Pilates can be done very inexpensively.
Thank you. Is there such a thing as wheelchair Pilates?
There is such a thing as seated Pilates. So I absolutely do work with people in wheelchairs. I have sections on my website that are for people in wheelchairs. So we do a lot of seated things. So yes.
So people asked if you teach other places besides DC. Do you want to just give a short answer to that? Where they can find you and how they can find perhaps a Pilates teacher who specializes in neurological conditions such as you?
So I have trained about 1,500 people around the world. So my most recent teaching trip was to Paris. Pre-COVID, it was to Dubai. So I have people trained literally all over the world who have trained with me specifically on working with people with neurological conditions. And obviously Pilates for MS is my main thing because the one I know the best. So people I have trained and myself work on Zoom as well as working in studios. But if you want to find studios on the Neuro Studio, there's a find a teacher section, or you could email info@theneurostudio.com and we can find you a teacher. Most places, if you live near, I wouldn't even say a major city, because we've all over the US, we have people, Canada, Europe. So there's lots of people I've trained.
Yes, you have, including me. I very much enjoyed your training. Someone wants to know, is it equally beneficial to do mat Pilates as the machine?
I would say, well, there's lots of different machines. So I would say it can be. It really depends on if you need a lot of assistance. So during COVID, when I was working with some of my clients who use wheelchairs on Zoom, I was wishing I had some of my equipment to work with them, because like when I was talking about stability and things like that, like I can help people get stability. I can help offload weight of muscles using all these things that I have that have springs and stuff like that. But you know, I did mat stuff a long time before I did machine stuff. Because I couldn't afford it and I didn't have access to any of it. So I would say it's a case-by-case basis, but for a lot of people, you can have very, very good results doing non-machine Pilates.
And you talk about PT or physical therapy through your neurologist or doctor, or Pilates or a Pilates studio classes for seated Pilates. What's the difference between physical therapy through your doctor and Pilates?
Well, I would say physical therapy is always based on the physical therapist, and Pilates would always be based on the teacher, right? So it's like, really, what is the training somebody has and what is the approach somebody has? I would say if you're going to a physical therapist, I would look for somebody who is a neurophysical therapist, like somebody who specializes in neurological diseases. And hopefully, if you are seeing someone and you have foot drop and they aren't addressing anything other than your foot, I would say maybe go to somebody who has like a broader approach than that. I think a lot of times if you go to a PT who's maybe straight out of school, what you end up with is somebody who has a very narrow focus on what they learned in school. And so they're like, okay, you have foot drops, so I need to stretch your calf and like whatever. And it's like, but maybe that doesn't help somebody's walking. And not that I'm saying you don't need to stretch your calf and that that's not useful or that Botox doesn't work sometimes or whatever. I just, in my experience, a lot of times it's kind of weird. I think you had asked this question, Mindy, about where you thought it was confusing that I said, if you have foot drop or walking problems, you really need to strengthen your calf muscle instead of strengthening the muscle that lifts your foot. And that was something that a lot of people talk about. And I'm like, your calf muscle and that push off part of walking is where your knee bends and actually can help clear your foot through a lot better than trying to work on that tiny muscle that lifts your foot. Like you can actually get much faster, better results by strengthening your calves. And also strengthening your calves can help, strengthening and moving your calves can help with spasticity in the back of your leg. So figuring out stuff like that. I've had some very good and some very bad PTs. So, and also I've had some good teachers and bad teachers. So it's just say, look for a neuro PT if your doctor is recommending someone.
Thank you so much, Mariska, for being with us today.
Absolutely. Thank you so much for having me.
A wealth of information, and it's so unique to have someone so knowledgeable and also has been through this journey. You are truly a warrior. So thank you so much, Mariska.